Yes, now you are audible.
Okay. Uh, Good afternoon, everyone, and myself, Dr. Bhabesh, and today's topic is zoonotic disease in infant, an uncommon but important cause of prevalence. And as you all saw in the picture, that there is in center, there is a family with their child, and there are multiple animals, so which the disease can be transmitted to the human beings. And today we are going to discuss some interesting disease which can be or maybe lead to the human infected. Next slide, please. So uh, uh, this is a 5-day-old baby who presented to us with the high-grade fever on day 5th of life, with poor feeding, letharginess, respiratory distress, fatigue, and hepatomegaly with along with the huge abdomen was there. And on ultrasound, it shows that it is ascites. Next, next. Sorry. Next, please. Next slide. Next slide, please. Okay. So on background, baby was born from 39 weeks of pregnancy with a 30-year-old primary mother, and who has history of one dengue, 37 week of life, and who was hospitalized on that one. Next. And baby was diagnosed on based on the history and clinical finding. Baby was diagnosed as a neonatal sepsis, and for that one, baby was started on antibiotic after sending the initial septic screen by the CRP, CBC, blood culture. Baby has received ventilator and non-invasive ventilator support along with the inotrope, because at that time, baby has feature of inotropes. But in spite of this antibiotic and support, baby has persistent fever even after the 3 days of the treatment. And platelet count is also dropping. Initially, it was 1,20,000, now decreased to 60,000. The in view of this persistent fever, and when we sent investigation, that also came, which came septic screen was negative, but liver enzyme was raised. So in view of this persistent fever, less thrombocytopenia, and maternal history of dengue, we just send NS1 and IgM of the dengue, but as a DD, not as a primary focusing of the disease, but as a DD, but which came to be positive. So after that, once this NS1 and IgM came to positive for the dengue, we stop antibiotic confidently, and given this supportive management in view of the initially increase IV fluid and later on decrease it. Gradually fever subsided, baby improved and got discharged as well. Next. So this is the second case. Next, please. So this baby, 1 year old, presented with the symptom of fever, poor feeding, irritability, and jaundice and hepatomegaly. Again, on the history, next slide. Parent has the farmer living in the rural area, and they have mother has uncomplicated pregnancy, and baby had normal delivery with no any registration and no any problem before that one, before this disease. So clinical scenario was that on examination, baby has fever, poor feeding, irritability, icterus was there, and hepatosplenomegaly. Our DD was sepsis, toxoplasma, viral hepatitis. Investigation with SANE is shown that CRP was there, LFT deranged, and blood culture came to be brucellosis. In this case, IV fluid was started. Initially, the antibiotic was started as per the unit protocol in view of the sepsis. Later on, when this brucellosis comes, then antibiotic as per the sensitive pattern, and baby also improved. Next case. This is the third case. This is the 15 days old baby came in emergency. This is the 4 year back actually, not in the recent time. So 15 days old baby came in emergency with fever, letharginess, and respiratory distress. Baby was intubated in view of respiratory failure because he was not maintaining the saturation. Septic screen sent and initial antibiotic and supportive management given. in perspective of the suspected sepsis, late onset sepsis. CRP and WBC was raised, but blood culture came to be negative. Fever was persisting, so history was revised again in detail, and then we come to know that father has history of COVID 6 days back prior to this baby. So sample was sent for PCR, which came to be positive. Once this came to be positive, antibiotic was stopped, supportive management given, baby improved and discharged. Next. So saying this, all the cases, we come to know that disease from the ancient days, this human and animal are live together, and now in the urbanization and increase in development, this distance are now narrowed down. So human and animal live together, sharing the disease with each other. So zoonosis disease is in fact the disease which is actually common in the animals, and from there it comes to human and infect us. So here in the picture also, we see that the disease causing agent is infected actually basically to the animals, different type of animals, where it act as a animal, this animal act as a reservoir, or many times asymptomatic, or sometimes symptomatic as well. Here this disease identifying agent can be can be gene recombinant mutation, morphological detonation, and when this animal come to the contact with the human being, that this disease causing agent infect a human and cause the disease. So basically, this zoonosis is the animal disease which come from the animal, especially the vertebrate animal. Next slide. Next, please. So mode of transmission may be direct, maybe cyclogenosis. That means one non-human vertebrate is required for the multiplication, and from there this come to the human being. In metagenosis, there will be one vertebrate and one non-vertebrate animal will be there for multiplication or completing this infective cycle of the disease itself. And in separogenosis, okay. So in classification wise, there are multiple agents. So we see, you all see in the slide that they may be bacterial, viral, rickettsial, protozoal, helminthial, fungal, ectoparasite. So various actually agents are there which cause disease to the from the animal to human beings. Next slide. So, coming to the neonatal zoonosis, transmission may be transmitted from the congenital, perinatal, and postnatal. And for the prevention part, we have to maintain the hygiene, especially the environmental control. And early diagnosis supportive care is very crucial for the outcome, because if it is not diagnosed, because as we see in the example, that initially baby was managed as a neonatal sepsis, but baby was not improved with the unit protocol or antibiotics. So when the disease, the history was improvised, and then there is some link of the suspected zoonosis disease, and it was diagnosed earlier, so discharge were possible. Otherwise, the fatal outcome may be happen. So here the hygiene and environment control is very much important, as well as the awareness and education of the society as well as the parent for preventing this disease. For the management part, next slide, please. So basically, next slide. Basically, the hydration and nutrition is there along with the respiratory support and the disease-specific antibiotic. Because if, as we see in the slide, if toxoplasma, pyrimethamine sulfadiazine, but if brucellosis, then doxy and rifampicin will be the choice. So depend on the cultural grow or diagnosis made, the antibiotic and the support will be required to manage this neonatal zoonosis. Next. So here the parent or close relative is a risk factor, and this need to be understood for the disease management. Most of the time the presentation is non-specific, and it is similar mingle with the neonatal sepsis. So early suspicious is required for the diagnosis as well as the management. And for preventive part, as we discussed, it is education and awareness of the regarding the zoonosis disease is required. Next slide, please. So now this is the case 4. This is an 11-month-old infant presented in emergency with history of fever for last 2 days, vomiting, sudden onset of altered sensorium, and followed by the seizure, abnormal movement. Next slide. On examination, child was febrile, poor respiratory effort by there, tachycardia, no organomegaly. Child was intubated and shifted to the intensive care unit. And there, this ventilative support, IV fluid, antibiotic, started with the vancomycin because of their unit protocol. And investigation showed that hemogram was within normal limit, blood culture was sterile. In CSF analysis, as baby has the history of seizure, so protein sugar was normal, but there was some pleocytosis which are lymphocyte predominant, and culture was of the CSF is also sterile. But JE, when sent at IgM JE, it came to be positive, and so the supportive management only is there for the treatment part for the Japanese encephalitis. But yes, for the prevention, vaccine is there for, and in Bihar and nearby, it is available free of cost by the government. So this disease can be prevented by the vaccination. So that is the important thing to manage the baby. But for the management part, it is only the supportive management. There is no any specific antibiotic or antiviral for this management. Next, please. Next slide, please. Next. So here, as we see that case fatality is 20 to 50%, very high, and that's by the awareness and the vaccination is very much important, as well as the education and community involvement. And as we see in this one, that pig is an important reservoir along with the mosquito. So in this case, we have to use the mosquito net as well as the use of the vaccination, Japanese vaccination to preventing of this disease. Next slide, please. So in this case scenario 5 now, infant come to the emergency with high-grade fever and chills, irritability, and respiratory distress. On examination, there was hepatosplenomegaly was there with generalized lymphadenopathy and breath sound was decreased on auscultation. In the investigation, there was thrombocytopenia and leukocytosis were there. Again, next. So differences were there that either maybe baby was suffering from malaria, leukemia, dengue, bacterial infection. So all investigation are sent to rule out this all the thing, and so one supportive management along with the antibiotic was started. But fever was not subsided even with the your first line and second line of the antibiotics. So during the next slide, please. So during the visit of the consultant round, it was seen that with the detailed examination of the patient, there was one scar behind the pinna. So one suspicion of the scrub typhus was there. So now the investigation was sent for the scrub typhus, which came to be positive, and then your azithromycin started and they will improve within the 2 days. So even after your first line and second line of IV antibiotic, we were not intubated, but with this narrow your specific diagnosis, baby was improved. And this scrub typhus initially supposed to have mountain fever. Actually, when I was working there at that time, I used to hear that it was in the mountain, and that's why it's the common. But now it's common in the Bihar itself, and in AIIMS Patna also this scrub typhus is diagnosed commonly and treated very well, and maybe improved. So next slide, please. So here it is transmitted by the mites. Incubation period is 7 to 21 days. And your local prophylaxis systemic dissemination will be happen. Generally, mite bite is the important, and there is a specific scar. There is this is the your clinical symptom which, through which the baby can be present. That is fever, headache, myalgia, lymphadenopathy, pharyngitis. Through this, baby can be present. Next slide, please. Next. Yeah, this is the cycle of the your scrubber typhus through which this can be transmitted to the human beings. Next slide. So it can be diagnosed with this wheel Felix, actually the old one, but now with the IFA, immunofluorescent assay, and ELISA, which is the most highly sensitive and specific for the diagnosis of the scrub typhus. And many times, if the baby not improve with your normal antibiotic, in that case, we can think about this as scrub typhus with persistent fever, and it can be treatable. So early diagnosis is very much important. Uh, so here we can prevent, because prevention is very much important rather than the treatment. So avoiding the vector infestation area by the vector control, wearing protective clothes, and early treatment with the doxycycline. Next slide. So this is the last case scenario now. A child present with the fever, nausea, vomiting, agitated, altered sensorium. On examination, encephalopathy, feature of the raised ICP, possibility of encephalopathy was there, so included your Japanese and herpes, but it all came to be negative. Here, again, baby was started with the mechanical ventilation and with your supportive care. Rapid worsening was there despite of all the intensive care. JE, SAB, PCR, malaria, scrap type, all are came to be negative. But there was a history of dog bite 1 month back, but baby was not taken for the post-exposure prophylaxis. The one rabies was diagnosed, and it was not only the dog is a reservoir, but other animal is also a risk for the transmitting of the rabies. And for this, there is no any treatment actually, and very fatal disease. And hydrophobia is also there. But only thing is, which is the preventive part is the your vaccination. So if after the pre-exposure vaccination is also there as well, which is mainly important for the person who is working the lab or a veterinary doctor. At the same time, if for the common people, if after post-exposure, we can take this your rabies vaccine, which can be 0, 3, 7, 14, and 28 day, through which we can prevent this disease. But once this disease is happening, that industry. So hand hygiene is very much important when you touch the animal or animal product, person contaminant environment. Vaccination, as we discussed, like rabies, Japanese encephalitis, there is a disease which are very fatal but can be preventable by the vaccination. So vaccination is important, very much important for the preventive of the zoonotic disease. So avoiding exposure to the potential infected animal, proper food handling, especially we have to avoid consuming unpasteurized food product, uncooked and partially cooked food or meat, and vector control. Again, as many diseases come through this mosquito, tick, and rodent bite, so we can prevent through the net and using the repellent. Next slide. So, majority of the as per the summary, majority of the human infection disease have animal origin. Not only cause the disease in animal, but they also lead to the serious threat to the human. And we also this one the COVID-19 pandemic. And robust active surveillance is required to targeting the other component to improve this zoonosis disease. And accurate detection of the zoonosis is very much important for the effective control of the measures to decrease this zoonosis disease. Next. So, this actually from this your zoonosis is ancient from the as both human and animal are live together, but now in the recently, as per the development, increase in development, cutting the forest, many animals who are live in the forest now have forcefully live with the your human along with the human, and that's why this many diseases are now it's prevailing, which are initially common for the animal, now coming to the human being. So there should be a balance between the pragati, that in the development, and prakriti, nature. And if this maintain, then hemodialysis will continue. Otherwise, there is chance of destruction is there. Thank you very much, and I'm very much sorry that initially I'm not able to share my slide. For that one, I am very much sorry. But thank you again for patiently listening.
Don't be sorry for about that, Dr. Bhabesh.
Thank you.
Thank you very much for walking us through such an interesting series.
We see zoonotic diseases in neonates and infant. Is it a common differential, sir?
No, actually, it's not very much common, but it's also not uncommon. So, when our regular disease management is not lead to the improvement of the baby, And if there is revising history, if there is a history of some exposure, in that time we have to suspect, like in the previous slide, which are the recently actually happened in our NICU, that baby was not improved with the usual management of the antibiotic even after the upgradation of the antibiotic. And when we take the history again to find some clue, and then we got the history that mother has some dengue, and she has hospitalized also at the 37 week of life. So we suspect, and we just send it for the rule out, not for the proving the disease. We think, okay, we should do this one also, along with the differentiation, and we are sending the blood culture again, and then it came to be positive. So it's not common, but it's not also uncommon. So if there is history in the parent, and if there is anything, then we have to suspect, like a scrub typhoid. It is now very much actually happening in the tertiary care center, that scrub typhoid is diagnosed as a primary disease and it is treatable.
Yes, and I would like to just add a couple of things to what you have said, Dr. Bhabesh. Over the last 13 years or so, for combined antibiotic discussion with NICU, which happens every week, I have seen this trend going up, and also with pediatrics department, we are seeing this trend going up, and this earlier people would take longer to suspect. Now it is one of the initial workups that people do, especially in the seasons when say for diseases like scrub would be expected.
Yes, madam.
Yes. Maybe Dr. Kamal has joined in, Rachna.
Yes. So, Dr. Kamal, do you want to ask the question? You were raising the hand. If not, then we'll move on to the next question asked by Dr. Panda. Among the 10 zoonotic diseases in our setup, such as in adults with prevalence, scrub typhus, leptospira, influenza, cysticercosis, rabies, tetanus, brucellosis, toxoplasma, anthrax, and Japanese encephalitis, which are you seeing in the children, especially infants, and what is the most common way to prevent majority of them in our setup, considering our animals also live with us without vaccination?
See, scrub typhus is common, which we are seeing in the infant and also in the children group especially. And along with that, this toxoplasma is there, which is common especially in the neonates and along with the infant. But for the animal part, actually very difficult without the vaccination. So who who have this pet, they have to be must vaccinated, so that we can prevent this this rabies and other causes of the disease. And other thing which I saw is the Japanese encephalitis, actually in the emergency and when in tertiary care center, this Japanese encephalitis is also very much common in the, especially in the 4 to 5 year of the age of the children, which come to the emergency with the high grade of fever 1 and 2 day, with the abnormal movements, suspecting AES. And here it's common to send J for the proving the disease. So J is coming. So J, this scrub typhus and the toxoplasma.
Okay, so the three of them are quite common in infants and neonates. Fine. So if there are no further comments, okay, so any other comments, feedback? Well, then we will conclude the session, and I would like to thank our both the speakers. Okay, so there is one more question. I would take it up by Shashank Srivastava. He's asking, are we moving in a phase of inappropriate overuse of doxycycline? As I can see, physicians and intensivists using this molecule anytime if fever is not responding by third day.
This practice is also inappropriate, madam, actually, that if the patient is not improving, we have to just judicially or empirically using this doxycycline. It's better to send the investigation for the scrub typhus. Like in AIIMS Patna, there is facility to diagnose this one. So once we sending this for the scrub typhus, especially a strong suspicious, and if it come to be positive, then only we add this one, your azithromycin or doxycycline. Just measuring this doxycycline in view of a scrub typhus, and there is no any facility that, then it's irrelevant, because doxycycline itself is a side effect. So it's not a good practice. It's better to send scrub typhus, because nowadays very much common actually what I see in the tertiary care center.
Thank you. Thank you for answering the question, sir. So, if there are no further questions, I would like to conclude the session by thanking our both the guest speakers, Professor Rakesh Kakkar sir and Dr. Bhabesh Kant sir.
Thank you.
And, the sixth webinar of our webinar series will be in March tentatively. And I would request you all who have joined to kindly give the feedback via scanning the QR code that is visible on the screen. And we will also share with you the feedback form. You can also fill up the form and share it with us. Your feedback is quite valuable to us.